The first one was what we talked about earlier when you're doing a mini open incision with a lateral. That one's kind of the easiest. And then now, I don't want to sound like a gomer because I use some sort of like posterior stabilization device that's not a pedicle screw. I never thought in a million years that I would ever do that in my practice, but it came a utility for me when, you have these really old people that they basically need a laminectomy, but they might need slightly more than a laminectomy, but you're not sure that you want to take them to the hospital and put them through a bigger operation with interbody spacers and pedicle screws and big open decompressions. And so I started to say, like, well, what could I do for those people? I could just do a laminectomy, and then let's say it's not powerful enough, I can then take them back and do a revision decompression, PLIF, ALIF, pedicle screws, and they're already 80 or 85 years old. Their bones aren't that great. And so you think of failure points, the more screws and rods you put in somebody in cages, the more failure points you're going to have. So I started to think about interspinous, interlaminar fixation devices, more minimally invasive devices that can be placed through a laminectomy incision, but still doing a very thorough decompression. You cannot cut corners just because you're kind of cutting corners on the instrumentation. And the other thing is when you're thinking of failure points, putting on an interlaminar clamp that fails has almost no repercussions. You can easily open up the laminectomy incision and take the clamp out and percutaneously put screws or put in a cage. The revision is going to be much different than if you've already put in big screws and those have wallowed out and now you're cementing them in place and all this stuff. And taking out old hardware, it becomes a much bigger deal for the patient. So in terms of like when you're having a risk benefit conversation, like I said, I never thought I would do interlaminar or interspinous devices, but I sort of convinced myself that actually it's probably safer for the patient as they get older because the failure mechanism is easy to treat. The other thing is you can do a much wider decompression, pack bone graft across the facets or the transverse processes and in between the spinous process and put a pretty minimally invasive device in. So that's how I got to that. Let's say someone has severe collapse of their foramen, total disc height collapse. Their spine's actually pretty stable, but they've got a little slip, and I need to shave pretty wide over those facets, and there's no autofusion. And the person's, 78 or maybe a little frail or 82. I would go in, I would remove the inferior portion of the spinous process, leave the rest. I would shave the bottom of the lamina, reflect the ligamentum, and test both sides of the nerves right then and there. And then there's a little distractor device that you can keep the probe on the nerve, keep it targeting, and then you can distract 2 or 3 millimeters at a time while sweeping with the probe and getting your reading down to the lowest reading and distract again and keep sweeping, and you're watching it go down. You're starting at a 6 and you're like, wow, that's already a 4 with just 2 millimeters of distraction. And you keep doing that until you get a good number or a good level of distraction. The thing you have to be careful of, though, is number one, you still have to do your decompression. You still want to, but also, two, you don't want to make this a kyphogenic procedure. You don't want to have to lift them 16 millimeters on the back, and now you've created kyphosis for a patient who already had a flat back. And so it's a balancing act. You have to be thinking critically when you're doing this to where, hey, I want to do as little decompression as possible to get the patient feeling better, but I also want to do as much decompression as I need to do, not to have to put a massive kyphogenic implant into this patient's back or something that's going to distract so much that the first time they stand up, it's going to crack their spinous process because you put too much pressure on it. So the other thing I did was I used a laminar clamp, which I think is different and more powerful than just a interspinous clamp. So I think I can lift a little more, and you can watch it under live x-ray. Every time you open it up, you see it opening up. So yes, I think if you're going for direct/indirect decompression to do a sort of a minimally invasive, quicker case for an older, frail patient who can't stay under anesthesia for a long period of time, this is a game changer. You go in, you do a little hemilam on both sides, you start testing, you open it up as much as you think you need, see if the nerves go good. If they do, maybe you do a slightly bit more decompression just for good measure, and you put the implant in and clamp them down. And then, like I said, worst case scenario, sometimes you do have to go back, or sometimes you do a Wiltsey approach with a tube and take the facet off and drop 2 screws in through that incision, which is still a minimally invasive outpatient procedure. But in my experience, and this is how surgeons always talk, it's totally anecdotal, I have had one patient that I know of that I had to take back and do something more after this procedure. So the odds are, and I haven't done that many, but let's say 20, the odds are still in my favor that the other 19 patients are doing great with a very minimally invasive procedure that they recovered from in a couple of weeks rather than a couple months. So yeah, I think there's 2 or 3 ways that this technique works. One is, of course, through anterior lumbar procedures and anterior cervical procedures. You can over distract both of those areas and pretty simply test the nerves while you're doing it. From a posterior aspect or even a lateral aspect, you can do that too. I've done it with PLIFs. Sometimes I'll stick the PLIF trials in one at a time and test the nerve while it's sitting in there. And I'll keep doing that, and I'll upsize until I get diminishing return. And then I know, okay, I don't need to go that tall. I can go much less. It also can help you know, like, we don't have to cram a 15 millimeter high cage in sometimes. A 10 might be good enough. And if you're sticking a 15 millimeter or 12 or even 13 millimeter cage in, and it's a static cage, you're going to irritate the nerve. You're going to be putting that thing right past the nerve root, or you're going to be distracting the spine so much to get that thing in there that you're tractioning the nerve root as you're doing it. And so I think knowing when enough is actually the best predictor when you're doing either a PLIF, TLIF, or even just a posterior stabilization interlaminar device or interspinous device. Those are going to be the times where it's like, yeah, I lifted it up 3 millimeters, 4 millimeters. That was good enough. I don't have to go up to 15 millimeters and check if I should go taller, but it's going to tell me if I do. You know, if I'm working and I'm lifting and lifting and lifting, you will see a diminishing return. Absolutely, there's no question. I've seen it in all kinds of cases.